One of the interesting things that we are considering now is if we need to add an anti-CD20 antibody to the therapy. We do recognize that anti-CD20 antibodies can work in CLL. Perhaps they don't work as well as they might in other lymphomas. And we've actually now learned that rituximab probably doesn't add a significant benefit, at least to ibrutinib in the frontline setting. We've had at least 2 trials, randomized trials of ibrutinib either with or without Rituxan, and shown no difference in the outcomes for those patients, suggesting that rituximab probably doesn't add much, if anything, to a BTK inhibitor. However, we do now have a second generation or newer generation anti-CD20 antibodies, in particular obinutuzumab. And I mentioned that ELEVATE trial of acalabrutinib, the next generation BTK inhibitor, was looked at either with or without obinutuzumab. And the acala-obinutuzumab arm did have a progression-free survival advantage over the single agent acalabrutinib alone. It doesn't appear that there's a survival difference between the 2 different arms. They're approved where you can give acala as a single agent or acalabrutinib with obinutuzumab, and it's a choice between the patient and the physician of if you want to add the anti-CD20 antibody or not. Maybe you would want to add it because you want to extend progression-free survival, but it's important to remember it comes at a cost with some infusion-related reactions, probably a little bit more neutropenia, and maybe even febrile neutropenia when you add the antibody to the BTK inhibitor, at least obinutuzumab. The other unanswered question is, should we be using BTK inhibitors or should we be using venetoclax, a BCL2 inhibitor? And we do know that there is data now that led to the approval of venetoclax in combination with obinutuzumab in the frontline setting. The beauty of that study, where it was compared to chlorambucil and obinutuzumab and shown to be very advantageous, not surprisingly, the beauty of that study is that it's 1 year of time-limited therapy. So it's very appealing perhaps for a younger patient, someone where they want to get some treatment, have the treatment stop, be off of therapy, hopefully for a considerable amount of time, and then if and when the disease comes back, they can be re-challenged as well. One of the caveats that we have to remember, though, is that the people that do the best and the people that come off of therapy at a year are typically people who become undetectable for minimal residual disease. Now, fortunately, the majority of patients are able to do that with that regimen and come off of therapy, but the high-risk patients are proving to not become undetectable for MRD, or if they're showing that their MRD level is rising at the year end point, they probably don't want to come off of the drug because they're going to relapse quickly. How you choose between the venetoclax obinutuzumab regimen or a BTK inhibitor, either with or without obinutuzumab, comes down to a judgment call and a feel between the physician and the patient about what might be right. There may be comorbidities that would drive you away from a BTK inhibitor and towards venetoclax. They could be things like bleeding risk, people on anticoagulation, or they may be things like renal insufficiency that might drive you more to a BTK inhibitor and away from venetoclax. These are discussions that we commonly will have with patients every day in the clinic. And remember, if you are on the BTK inhibitor, you are on single agent BTK inhibitor indefinitely till either you progress or until you become intolerant to treatment. And that leads us to where we're going next. And that's combinations of agents, in particular combinations of a BTK inhibitor with venetoclax. Actually, even 3-drug combinations are emerging, ibrutinib, venetoclax, and obinutuzumab, or acalabrutinib, venetoclax, obinutuzumab. These agents are proving to be in combination very, very powerful at achieving undetectable MRD, and that's allowing the opportunity to again give time-limited treatment. We do understand that the ibrutinib venetoclax regimen, and likely down the road a acalabrutinib venetoclax regimen, these regimens will be approved, and combinations might be also the way to go, again, either with or without an anti-CD20 antibody.